the C4H Weathering Change Seminar Series. Today's speaker is Renee Mahaffey Harris from Closing the Health Gap, presenting on impact of climate on the health and marginalized populations. I would like to share a few announcements before we begin. Attendees will be muted until the question and answering portion of the seminar, where you'll be allowed to unmute and ask your questions. You can also put in the chat any questions that you have, but I most likely will call on you. You will receive an email after the seminar concludes that has an evaluation link, as well as links to the C4H website and YouTube playlist to view upcoming events and recorded past seminars. Thank you.
First of all, thank you for having me, Professor Davis and Jessica. I look forward to this conversation that we will have on climate change and its impact on marginalized populations. So the objectives I hope to achieve with this conversation is define climate and environmental factors that contribute to health disparities, understand health disparities and why they exist, and understand how climate change and environmental factors disproportionately impact the health of marginalized populations. Before I get started, I wanted to just say a little bit about Center for Closing the Health Gap. We're about 22 years old, and our work every day is focused on building a culture of health across the greater Cincinnati community. And we do that by engaging health systems, academic institutions, health providers, community residents, utilizing a community-based participatory research methodology in all that we do, so that we can educate and understand what that education needs to be from the very people who are being impacted, so that they are more empowered from how they access healthcare to understand how to advocate for themselves in the doctor's office, understanding how to navigate healthcare systems, and practicing ways to increase their lifestyle, which is the exercise, what we eat, and how we manage all of that mentally, so that you can be better able to advocate for yourself. Talked about the learning objectives already, so let's move on. So you have to bear with me as I get used to this clicker. All right, so the impact of climate change on human health. Some of this you may know, depending on who is here listening, and some of this is logical and some of it isn't. So when we think about, the rising temperatures, and we think about some of the more extreme weather we're seeing across the country, as well as rising sea levels and increased CO2 levels across all of our country, the impact of that, this is what we're going to explore today, but the impact of that is that severe weather is impacting injuries and fatalities and mental health impacts, asthma, cardiovascular disease, changes in the vector ecology, which, diseases that we hadn't seen before, how we're seeing them now, from malaria to, and some of these words I can't say well, so I'm not going to butcher them. I'm going to say the ones I know that I can say: Rift Valley fever, Lyme disease, West Nile virus, and I know that we've all been kind of watching what we're hearing about Ebola in Africa. And then increased respiratory and allergies and asthma in populations that are in those warm, or in center cities or urban centers where there's more warmth and climate and heat because of the building and the density. Also, forced migration, civil conflict, mental health impacts, and then other related health diseases that are leading to earlier incidents of earlier and premature death from cardiovascular failure and other diseases. So temperature change. I guess if there were people here and I could say, raise your hand. I think we're all seeing the impact of temperature change. We're seeing, our spring and our winter and our fall kind of merge together. We're seeing this earlier, these hotter temperatures, these climate tipping points, as we're seeing from this slide, show us that, we keep rising, right, there's going to be some trigger and large impact that is not going to be reversible because we don't necessarily control the heat, right? Or we don't control those climate shifts. And so I think those are the things that we want to talk about and explore and how we do our best collectively to address what we're moving towards. I know that many of you who are here who are in the environmental space, this slide is probably not going to be a surprise to you, but when you think of the greenhouse emissions that are further exacerbated by some of the weather shifts, think about the industry, right? And I know that we're hearing a little bit more about our power grid and the electrical power, and we're looking, and AI and where some of those substations are placed and what impact they have on the populations they're near. We already know about transportation and the particulate matter from the emissions and industry, which we've always known about. But when we think about the warming climate and our agriculture and the impact to agriculture and other commercial and residential, you see these percentages, but knowing that these percentages are going to be further impacted and exacerbated by the rising climate is something that we don't know where this end is, right? And so that's what we're here to discuss. This slide tells us a lot, right? Since 1960, this climate is our Earth has gotten warmer. And, I thought what was interesting to me is looking at the peak point of the springtime temperatures and the fact that springtime temperatures are kind of a measure. But when you look at 2000 and you see this big peak, and then you see a little leveling off in 2020, but again, high increases, so we're staying at that plane, even though it's kind of trending down a little bit, but it's still staying at that high level. And so that's, across 48 contiguous US states. And so it's not like the number is dropping severely because it rose quickly. And so we now have to start thinking about what does this change in weather look like to our economy? And some of the severe weather we're seeing across this world and our country in the United States, again, this graph is showing us what that looks like, right? So the monetary impact of weather systems that are creating larger scale weather incidents from hurricanes, and looking, in 2010s, and that's the 2010s. So obviously, I would assume that the data for the 2020s is probably still rising. But if you look at $487 billion impact of hurricanes, and that's 2010s. So, and these are things we don't control. We don't control the weather, right? So as I mentioned in the opening that I'm going to be talking about climate change as it relates to marginalized populations. And so some of these things, I'm going to run through some of these slides pretty quickly because most of you I know what health disparities are. You understand what the Centers for Disease Control says about health disparities. You understand what that impact looks like. I'm using the word marginalized populations because sometimes when we talk about health disparities, I think I've heard people assume that health disparities impacts particular economic groups, but the reality is that the research tells us that health disparities exist and persist regardless of socioeconomic status. It has to do with achieving optimal health. For socially disadvantaged racial, ethnic, and other population groups and communities. And so as we talk about climate change, we're starting to look at these centers where people live. And so we're going to see a variety of incomes in those places that people live in. And so we can't run from the weather, right? We can't run from the climate change. I think it's important to recognize that as we talk about health disparities, we talk about health inequities, that race is a social construct. And race, as you see from this photo, represents all of us. It's about our human health. As you think about health disparities and you think about the impact, I know we talked about social determinants of health, but I think when you look at this slide and you actually begin to see how the social, environmental, and economic inequities across economic stability, neighborhood and physical environment, education, food, community safety and social context, and healthcare system, and you look at all of those drop-down components to each of those categories, this is a pretty big, broad range, right? That affects all of us in some way, regardless. A lot of it has to do with where we live. A lot of it has to do with factors that necessarily aren't in our control. I always like to refer to the data and refer to the fact that an unequal treatment, this exhaustive research study that looked over 18 months, 600 different papers, to really help us understand the evidence and why health disparities persist. Race and ethnicity are significant predictors of healthcare quality. The vast majority of studies indicated that minorities are less likely than other populations to receive needed services, including clinically necessary procedures. Some of this is about the trust or mistrust or understanding of systems. And I think when you start looking at the data around unequal treatment, this unequal treatment document done by the Institute of Medicine, I think we begin to better understand that when you look at health disparities, the biggest predictor and the biggest evidence is life expectancy. So let's just take a look at this life expectancy chart here that was done in 2019 and 2021 by Kaiser Foundation. And it's really helping us better see how life expectancy is impacted and impacts across race and ethnicity. Some of this is probably not a surprise to most of you watching or listening, but again, we're setting the stage around the fact that climate change and marginalized populations and this impact. So it's really, I think, important to understand that some of these life expectancy factors were already predictive prior to this increased climate change. So that's really what I'm trying to get you to think about as we look at these slides and continue this conversation. I'm gonna flip through some of these slides because I think it's just important to really understand. When you look at health disparities, I think oftentimes people talk about the economic, but we'll use infant mortality, which we hear about a great deal, because infant mortality rates aren't necessarily predictive by income, right? And I think the perception is that that's what and why. And so, when you look at this chart and it's showing us, this percent of women who are impacted by infant mortality, and you're seeing that those women often are very representative of women who are at the higher end of the economic spectrum. And so it brings into question why. Some of that has to do with health and cultural competencies of across different age spectrums, and really helping people better understand how to navigate the healthcare system. As I said earlier, with closing the health gap, regardless of income, the more that we can empower individuals and to understand the system they're entering in, and how it's a partnership. It truly is a partnership with your doctor and you. And so the more that we can bridge that gap in that partnership and what you share, what you talk about, I think we're going to see some greater outcomes in health outcomes, because I think we have a sick model system in our country. But when you look at countries outside of the US, you see more of a preventative care approach, right? So as we begin to talk to each other and understand that it is a partnership, I do believe that we'll begin to see a greater trust, and greater ability to really work together with practitioners, from the doctor to the PA to the NP to the nurse, to whomever you're interfacing with in your healthcare delivery system. So, rates of death, as highlighted by this data set, looking at some of the top disease factors that are impacting people racially. I really wish I could have more of a conversation with you about this, because I don't think anything on this slide is probably a surprise, right? Heart disease, is still, at that top of the threshold. And obviously we have COVID-19 in there, and that told us a whole lot, right? During COVID-19, when you saw this disproportionate impact of COVID-19 losses of life for specific populations in particular areas of the country, you saw it very much in urban centers as well as rural. And so again, it's that proximity to place, but it's also, what are the other factors, that environmental factors that people don't necessarily control. And, I don't, I'm going to put the folks in the room on the spot. I don't have anyone else to talk to. I can't talk to you all out there, but does anything surprise you about the age-adjusted death rates by race in this slide, for heart disease, cancer, other respiratory diseases? Does anything surprise you about this graph? No, it's what you would expect, right? So a lot of it. So, we all already know these facts, right? And so we're talking today about climate change and how that is another kind of accelerant to these disease outcomes for death rates. So that's why I'm sharing this slide. The next slide is, again, what we learned during the pandemic. And I think that's not a big surprise because we learned this over and over again. I want to talk a little bit about stress, because I think as we talk about climate change and we talk about, what does the impact of climate change on populations that are already marginalized around many factors, something that has really intrigued me of late is research that began with a public health expert in 1993, kind of called the weathering hypothesis. And yes, weathering hypothesis is talking about, I describe it like, think of a roof and constant rain or constant impact of some external factor. So when we've kind of gone through these slides and looked at the factors that contribute to disproportionate and death outcomes, as well as outcomes for disease factors, there are these compounding factors, right? And so we're here today to talk about climate change, but I think it's important to understand that these stressors on the body, so just the natural stressors, you compound that more with temperature and the allostatic load, which I don't think we all walk around saying, hey, how's your allostatic load doing? Right? But the allostatic load, when I say it, people are like, what are you talking about? I was like, okay, that center point of your brain, like, which is your fight or flight mechanism, right? And so your body is naturally responding, and your allostatic load is that factor that it's impacting. And so, how your body stays balanced by temperature, I'm not going to, and then how your body responds to stress and how that impacts your allostatic load in your brain. I think it's important for us to talk about that weathering component of our health outcome as we talk about climate change, because what we are going to see and what we are here to talk about is how health disparities and all of the factors we just talked about in health disparities, the climate crisis is a health crisis, bottom line. So that's why we're here. And we know these things. So the question is, like, what can we do? Because we can't stop the weather. We don't control the weather. Greater being, God, controls all of those things. But that climate change impact on our health is what we're here to talk about. And so this particular slide, I think, is a really great predictor. And I will say that I did not create this slide. This slide is from the American Public Health Association. But I think it does a really good job of looking at air quality, which, again, we don't control the air quality, right, that we live in. But if you look at the fact that 17% increase in the emergency room for households and individuals in 2023 from asthma, and then you compound that with wildfires across the country and other, natural form disasters or natural factors that we don't control, these more intense wildfires and what that's doing to our air quality, not just where they occur, but how that smoke and carcinogens kind of travel, right? We already know about the particulate matter from car emissions. And so again, as we look at this slide, and it's talking about the 2,000 plus deaths, 6,000 plus increased emergency room visits each year due to and aligned with particulate matter that we are breathing in. And then we start looking at some of the disparity factors. So, in 2020, it showed that that marginalized populations, Black people, is what this APHA site is talking about. When I think of marginalized population, I think geography has just as much to do with race, right? So in a rural area where you have limited access, I think that you potentially, and again, I'm not confirming that because I haven't done the research, but I would say that there's some compounded factors that you would see some 3 times more likely health outcomes that are focused around the asthma and other disease factors that are impacted by the conditions in which we're breathing, and or how we understand what we're being exposed to. So what really interested me, or kind of, in some ways it kind of frightened me, and I personally felt it myself, is like my allergies were kind of, I won't say they were dormant, but they weren't anything like they were when I was younger. They were worse. And so over the decades, though, all of a sudden I have to take allergy medicine on a daily basis. And I was like, well, what is happening? I'm not even outside that much, right? But seeing that, the ragweed season has increased, and it makes sense. And I'm sure that we all can probably relate to that. And then there were 2 parts of the country that specifically are pointed out in this slide. Minneapolis, saw 18 days of this increased ragweed presence, and Fargo, North Dakota. And so, again, across this country, we're seeing these extremes as they relate to air quality that is attributed back to our climate. And so when we start looking at this increased allergens and what that impact is on actual body, from aggravated cardiovascular to aggravated respiratory illness to mental health, distress, and increased allergy-related illnesses. That's what the air quality and climate change are doing to all of us. And it's not something that we really think about because we walk outside and we breathe, right? So, when you're starting to have these conversations in our communities that we serve, I think it's a harder conversation to have, because it's not something that you really, I don't know that we just think about the air we're breathing, and that there's a question about what's in that air, or how the temperature is impacting our body. This slide is about pollution. And again, this is what we have. I think this is what I've talked about a lot when I look at environmental factors affecting our health. I talk about pollution. I talk about, the location of construction and other entities near urban centers and in rural areas, and seeing the impact. And what this graph is showing us is the impact of, construction, power plants, other industrial and residential sources, where you live in proximity to highway systems. All of those factors contribute to the length of life and the impact, to other disease factors that have a lot to do with how we breathe, our lungs. And then we see the impact of diseases, right? For, lung disease to heart disease to cancer, diabetes, obesity rates, children's health. I don't know that we walk around thinking about how all of these pollutants potentially have an impact on our everyday health. And I guess in some ways it's hard to talk about it because it's like, well, what do you do? So I thought this slide was an interesting slide, just to look at your body and think about how particulate matter affects your body, from shortness of breath to wheezing and coughing, chest pain, fatigue, how that can worsen some conditions like cardiovascular disease, like heart disease, asthma, COPD, and seeing those increases in those diagnoses of populations that are in those areas that are just warming. And then, adding the ground level ozone pollution. And again, seeing, how that's affecting our breathing, how ultimately it's affecting the rates of asthma and as well as emphysema in populations across this country and communities that are already distressed. So, what are scientists saying specifically from the American Lung Association? And many of you, I'm sure, probably know this information already, but I think it's important to understand that groups may face greater exposure to pollution because of factors ranging from race and bias and housing market dynamics and land costs. So when we look at where people live, I know we can make the statement where you live affects how long you live. And so I think oftentimes when we think about that, we think about urban centers only. I was just on a national press briefing conversation on public health a couple of hours ago, and it was interesting to hear press talk about, and some of their highlighted stories were about the closure of hospitals in rural areas. Rural is entire, there are rural areas of all parts of our country. And so what they focused on was the fact that no one's really talking about this impact of, and I'm not actually talking about climate, but that does factor in here. But if a hospital closes in a rural area, you have to drive 100 miles or more, how that impacts the survival rate, how that impacts treatment. And so, so there's like all of these compounded factors. And sometimes we're very focused on one factor, but we are a country of many people. And so this is about the humanity and human health of us all. And so, we are having this conversation in the United States, but the World Health Organization is also having this conversation. So yes, we know some of the solutions, but some of those solutions take lots of more resources. However, we do need to focus on reducing emissions of greenhouse gases. We do need to look at other forms of transportation that can limit what that particular matter is that's going into the air in areas of our country. We do have to look at diversifying our energy use choices. And we have to, look at reducing driving trips and reducing air travel trips. And I'm sure, I don't know who's on this call, but, I don't own stock in airline or anything like that, so I can talk about these things. Just infrastructure and our home energy. And I think we see a lot of advances there with more solar panels. And that conversation is not specific to an economic group, it's for all. So I think we're making some great strides. When we look at growing our own food, granted, we don't live in California where we have a temperature climate that allows us to grow year round. However, growing our own food does enable us to have some greater resource where food access or food disparities or food deserts are a barrier and a real barrier across our country. Water use and how we recycle. I think we're all learning what recycling means and how to do it right and how to compost and just ways that we can preserve our earth. Again, there's a lot that we can do as far as educating ourselves, but we also are going to have to learn how to advocate collectively with systems, with academic institutions, with advocacy groups, because our health and the air we breathe and the climate change, which we don't control, are affecting all of us in some way. And so, today I hope that what I've discussed with you gives you an opportunity to think about this a little more broadly. We're all impacted by what happens to one of us, whether we want to believe it or not. So we have an opportunity to work more collectively around strategies that we can advocate on collectively, as well as helping people better understand maybe why they're seeing a greater need for more allergy medicine, and know that we can't change the climate, but we can make sure that we understand the why and be able to take better care of ourselves and work with our providers and work with other partners to address solutions that we can collectively advance. So with that, I'm done talking because I've been talking for a long time. So I would love for this to be a conversation. And so I'm going to move to my last slide, which is basically thanking you. And then let's have a conversation.
If I can get over it. John, you can go ahead.
It seemed quiet, so I thought I would jump in. Oh, wait, let me put my hand down. I think that was a great talk, and I think that, you know, you showed some interesting, really interesting statistics that, you know, I think in one way or another, I think most of us have heard some of these things in one way or another, as I said. I think though, I was especially struck by, you know, the comments you were making about, you know, hospital closures in rural communities and stuff like that. And I think to a very large extent, you know, the factors that you're talking about, and there's quite a range of them, you know, traffic pollution, access to healthcare, heat islands, economics, racism, you know, these things are all independently contributing and of course synergistically contributing to you know so many of the things, not just health, but you know, just all the many different ways that communities are affected. But specifically, you know, with regards to just like the hospital closures, you know, having worked in the healthcare setting for years before I went back to school to get my PhD, you know, one of the things I saw was just the difference between the nonprofit hospitals and the for-profit hospitals that I had worked in. And that change has really increased, you know, where you have for-profit corporations like Columbia HCA that buy up small rural hospitals, then consolidate those hospitals in order to increase the profit margins, completely without respect to the communities that those hospitals are intended to serve. And the same thing, and it's now even worse because you have such an interest in, you know, private equity acquiring these hospitals and then, you know, trying to spin them off in such a way that, you know, they basically bleed them dry for everything they can get out of them, and then leave the community without any health care at all. You know, and it's that is really, you know, accelerated over the years and is, I think, you know, really a concern and is a manifestation of our for-profit healthcare system. And it leaves people, you know, even in more urban settings, without access to healthcare because, you know, if you don't have insurance, it becomes very difficult to get, you know, preventative care. And for-profit institutions, they have to serve, you know, those people to some extent, but they're not going to provide, you know, good preventative care for those families, which, you know, drives up, you know, the infant mortality rates, which the United States has one of the worst infant mortality rates of all the developed nations. So, I mean, these things all tie together, and it's you know, economics and racism and everything all bundled together, and it's, you know, I look at this ball of yarn and I'm like, how will we ever untangle this? Sorry, not much of a question, but I think it's, you know, a discussion. I mean, so many discussion points here. You know, I don't know where to start.
Right. I know. So I'm glad that you mentioned the private equity because I saw a presentation by an author, and it was really kind of looking at one part of, I can't remember where, it was a rural area of the United States, and seeing the impact on a private equity group coming in and purchasing that system and so what exactly you said, and so, you know, that is happening across the country, and it's not just happening with hospitals, it's happening in housing. And
Yes.
so you're seeing, you know, I think I mentioned that I was on this call with National Press and they were talking about public health and they were talking about, you know, health is so many factors. And so housing has always been a factor, but it is even more of a factor, just as we talked about the hospitals closures because of private equity purchasing. The same thing is happening in housing, right? Yeah. And so, yes, there are a lot of compounded factors, but what I believe, because I'm a glass half full person, and I believe hopeful, there are a lot of experts in this room online, and in this country. And I think that there's going to have to be some greater strategy and conversation amongst the experts to kind of better galvanize what we know academically, what we know from research, and come up with some strategies that are going to help us believe that there is another pathway. I think from a population perspective, there's probably more people who are impacted, who have the knowledge and expertise that could come with some strategies where we could prove out something in some small geographies, that then can be greater applied to more places in the country. I mean, because otherwise we're just, all of these data points I shared and all of the information I shared is what it is, and it's only going to continue to grow. But I do believe that we can draw a line in the sand and begin to think about developing some strategies that we can test, reapply, and just as there are equity groups to invest in building more resources for people who already have probably lots and lots of resources, I believe that there are people who do have resources as well who would be willing to invest in strategies that can actually help address some of these compounded factors we're seeing around health outcomes and increased rates of early loss of life, for populations across our country. So I'm not saying I have the answer, but definitely think that we can put our heads together and our expertise together to begin to look at charting a different path.
Yeah, I think that's great. What do you think are some of the, at least in our region, some of the biggest areas that really need focus?
When you say areas, do you mean census tracts? Do you mean
in terms of, I think here, we have scientists who are experts in environmental related health, I'm just kind of curious, like if someone in terms of the Cincinnati area, what are some of the issues that most need, or where research could maybe help benefit development of policies, citywide policies, those kind of things. Do you have any thoughts on areas where we could focus?
so? Okay, so you mean geographic areas or just areas?
Research areas, I think, is really kind of what I mean.
Research areas. Okay, so I mean, there's a lot of research on asthma, right? And so, and I think because of that research, you can pinpoint where and why. And so I think some of the policies have to do with the ownership of properties that are owned by people who don't live in Ohio or in this region. And so from a policy perspective, the question would be, what can be done to change that policy that puts greater responsibility to that owner of that property? And again, I'm not an attorney either, I'm not a doctor either, but I do know that there is a clear path to see what that data. And so what could be, I mean, I think the step could be looking at maybe federal policy and then state policy. And, I know that the time we're in, that's kind of challenging, but I think if we use research and the researchers to be able to chart like the path, like here's the trajectory if we continue down this path. Because at the end of the day, we need all of us. And so I think that's one policy place that we could focus, because there is a lot of research here showing the rates of asthma and COPD and specific geographies and parts and census tracts in our region. So I think that is one that I definitely think we could move forward with looking at the policies that impact the people that own those properties, and whether and obviously I want the policy to affect anyone, but I do know that a lot of parcels of land are owned by people that don't live here. So that is one that comes to mind for me very easily. And there's a lot of research here that supports and helps us understand where.
Does anybody else have a question or comment, Terry? Just go ahead. Speak loud.
Yeah, so recently I went for Next with someone who works in it's 9 departments of that. Mentioned something that they did a study and found out that live around that's like way intersection, they tend to have very low, very poor health outcome and very low life expectancy. And in fact, the figure you mentioned was really bad. I think it said like 60 years or thereabout, way
16 and
lower.
22
Like,
lifespan gaps.
way lower than the Ohio average. So I was surprised, and I know the session is going to get more climate related events. So, like, what's your opinion?
Well, my opinion is that's a problem. And I think the data set you're talking about, there's a data set that looks at indices across the 500 major cities across the United States. And for us in this region, we're 16th in life expectancy, meaning that the gaps are 22 and 21 and years difference. And what makes that even concerning, and as I've listened to local elected officials from the council, their question is, why are our data points so different from Cleveland and Columbus? Because there's an 11 and 13-year difference in that life expectancy gap for Ohio, for us, to Cleveland and Columbus. And so I remember seeing this data presented by our health department, and one of the council members said, why is that? Because we're very similar to Cleveland in composition. So what would that be? And so I guess I don't know if I'm going to answer your question, but I think that's a great starting point. Why? So let's pull back the data points and let's see specifically where, because those life expectancy data are based on death certificates, right? So you can potentially map or do a heat map that helps you better understand the why. And then, so we do know it's an issue. I think we need to pull back the layers so we can look at what are those specific factors that are consistent for us that are potentially not consistent in Cleveland and Columbus. And that's going to give us a roadmap to finding some kind of solution to address that issue. And I think that's something we have to do, because do I want to be in a region that we have one of the lowest life expectancies? I don't think any of us do. And so that's something collectively we want to be better. And so I think the data, the research, and researchers, we can come together and we can figure out why and see what we need to do from a policy perspective to improve. And then also, who are the other partners that are impacted by that statistic? Because sometimes they're not, they're unlikely partners. And I think that's something we have to do more of, is looking at who are the other partners who are impacted by this type of great disparity or gap in lifespan.
Arda? Oh, sorry.
Yeah, thank you.
Wait a second, Arda. He's following up.
Or maybe I didn't hear very well, but you said something like it's not affected.
What was it about health disparities?
No.
Oh.
Infant mortality rate.
Oh, yeah, that slide that
It's
showed.
not affected by income. So I wasn't sure, maybe I didn't hear you very well. I was surprised, but I was expecting that it would be affected by income.
I agree that you would assume that. And that fact that data point showed that that's not the case, just like health disparities. Health disparities persist regardless of socioeconomic status. And usually the rooms I'm in, when we start talking about those inequities or disparities, it immediately goes to underserved populations, or not underserved, but people who are at a lower income. And I'm like, no, that is not what the data tells us. So I guess you're talking about this infant mortality slide. And again, I preface this by saying I'm not an expert, okay? But when you start looking at stress and other compounded factors that persist regardless of income, like that's the equalizer. And so I can only speak for myself. when I had my daughter, I actually had to go back in the hospital because I had complications. And at that time, it wasn't really described as infant mortality. And they couldn't figure out what was going on. Like heart rate's up and you keep hemorrhaging. But I knew enough to say, okay, let me call my doctor. Let me call everybody else I know. Because at this time, I knew some people I could talk with and say, hey, I don't, can you help me help who's caring for me, help get to a solution, right? And so sometimes, so when you look at birth rates and you see that income isn't the factor, some of that has to do with, and there's lots of studies to say this, how a person is able to advocate for themselves, I was at a conference, it was a women's conference, and a doctor from Grady Hospital spoke, and she shared her own experience of being in a hospital and trying to get some of her medical practitioners to respond to her distress. And they wouldn't. So fortunately, she knew a doctor that could call someone at that hospital. That shouldn't be the solution. And so again, I'm just giving that example that when you're in a hospital, I don't know if anybody can see your income, right? All right, so you are a patient. And so sometimes, we all have bias. We all have bias. If you say you don't, you're not telling the truth. We all have bias. And so I can't explain the mental capacities and how we allow those bias to enter into how we perceive something. But a lot of this is more perception versus medicine. Right? A belief that, there's lots of data to show that there are studies that show people being trained in medical school believe that certain populations have a higher tolerance of pain or that their blood coagulates differently. And so think about and it's not like, I don't think anyone's intentionally saying, well, this is what I believe. So it's got to be true. And so those are perceptions, and it's just going to take us time to be open and talk about some of these things. So that we can really make sure that we're doing the best for whoever we're caring for, and that we're allowing them to be a part of that care team. Because if you really listen to the patient's going to tell you some things that are going to, medicine is a science. Again, not a doctor. My daughter's in med school, but I'm not a doctor. But again, the formula is, it's both of us. So the doctor needs to understand what's going on, and that person needs to feel like they can trust who they're talking to and that they're going to be heard. So.
Okay, Ardith, you're up now.
Renee, thank you so much for that talk. I really enjoyed it, and it's very important in all of the climate work, even globally. I just want to make one comment and then sort of probe with some questions. So I think Akeem Bakari is in the audience. He's one of our doctoral students, but he's from Nigeria. Akeem, you're there, right? I think I heard your voice. Yes. And he said something that is last year or several years ago that is an echo of what is often said, which is that the people that are contributing most to the climate change problem are the ones that are oftentimes the most insulated from it. And the people who contribute the least are the ones that are maybe impacted the most. And I think that's even true within the United States, meaning low income and certainly with racial disparities and as a correlate with income or the ability to have air conditioning or, and then these underlying conditions that put us at risk. Nevertheless, I think, so that's a kind of comment, which is that this is something external that people who are disadvantaged, they really don't have the impact. People who may be most at risk are not the ones who are necessarily creating a problem, but they're just receiving the problem. But nevertheless, it seems to me that in our country, because of the marketing and everything else that's been done, people are not as aware of climate and heat issues as we would like. And then particularly some people who have underlying health problems are likely to be bearing the brunt of the negative health consequences. So it seems to me that this is a good opportunity and necessary for education of people who may not be, who may be minoritized and didn't create the problem, but to recognize their own increased risk, and kind of working at a community level for intervention. So I guess the question out of all that musing, I don't mean to go on and on, is, how do we also reach minoritized communities to increase their awareness of the potential impact of climate and extreme heat on their health? Are there strategies you can think of because this is an important goal for our P20 center.
Do you want me to respond?
Yes, please.
Oh, okay. So I would use, I'm going to use COVID-19 as an example of how we, Center for Closing the Health Gap, along with other partners, and at that point, we were all in our homes. And I was like, okay, there's got to be a solution. So I talked to the people I knew. I said, okay, we already have the data. Can we just overlay that data with the incidence of COVID? And then let's layer it also with all of the factors that we already know about the population, from disease factors, et cetera. Okay? And so let's approach the solution from what we know. And so I think that's more of like the research and the academics and all of the partner side. I think on the community side, we then started town halls that gave our community, we did 50 of them, and I was back end of those, but we had people in the community come on and share like whatever they were feeling. And we made it a space where, while, we might announce some new information, and then like a minute later, some national influencer would say, oh no, don't trust X. And so we created this place where we could have a conversation. And it wasn't a conversation of judgment. It was accepting that this is what you're hearing. So let's try to give you as much information so you can make an informed decision. And our work that we do at Closing Healthcare, which is, we're a small organization, but what we believe is that we don't have the solution by ourselves. And so when we are in a community, we're here, but we're going to talk, and we're not the solution. You are, because you live here. This is not where I live. So we want to make sure we can equip you with some knowledge that's going to help you understand why we're doing a survey. What questions do you think should be on the survey? And then we're going to teach you, and you're going to disseminate it. We're not. And so that approach for us has proved to be a wonderful kind of aligner, I guess, so that what we may know from the data, what we may know from research, then becomes a conversation with the very people who live in that community. And then that new knowledge empowers the individuals, so that, because we want it to be sustainable. We don't want to say, hey, yeah, we need to address this issue of, lack of access to healthy food, living in a food desert. We need this to be a conversation where and if we need more expertise, then that's when we reach into our partners and say, hey, we need you to come and be in the community and talk with the community, let them ask questions, so that there could be this true collaborative, participatory research approach around an issue. I will tell you, after preparing for this conversation today, I realized that we talk a lot about lifestyle, and I think now we need to begin to help educate, because people, what's beautiful is people from any walk of life, if you approach that person from the perspective of, I don't have the answer for you. When I sit in meetings, I'm like, I don't speak for all marginalized people. But what I can do is say that we are trusted. And because of that trust, if I say, hey, I need you to come talk to us, I need you to come. And so that is, I don't want to. Okay, so I think that can be risky, right? Because it's easier to know the data and say, okay, here's what the solution needs to be based on what the data says or what research says. But that doesn't mean that that's the pathway that's going to make sense and actually produce a result. So it's a risk to say, you know what, I don't have all the answers. But I think that risk enables us to actually build a table that is going to actually get to a solution. And so again, from being invited to speak today on climate change, I know that that is another pillar we're going to need to add to the work we're doing so that we get those voices as we're in the field and we ask. That's usually where we start asking different questions. We create different surveys so we can understand what people are saying and then make sure that we create, we call them in-person town halls now. So we've done one on mental health with adolescents and how to know what signs you see in your children. We've done it with men's health. We're going to be doing it with caregivers. And so I'm thinking that we're going to have one around disease factors and climate, what you need to know. So just talk about that. But again, we're trying to create these settings where we can bring the experts together, but also make sure that the individuals, there's a level set. We're all equal in our conversation and what we want to know and what we need to understand. I don't know if that answered your question.
I think that's a good start. Thank you.
You're
There's
welcome.
a lot of work to do, isn't there?
Yes, there is a lot of work to do, but we can do it together. So
Yeah.
I've seen it happen, and I think that we just need to be very serious and point out, here's what we need to work collectively on.
Yeah, so Renee, in working on this, first of all, you describe yourself as a small organization, and you are, but man, you have impact, a very admirable impact in the city, and we all know that and appreciate it very much.
Thank you.
Also, when it comes to climate, if we can partner in any way, just please let us know. We would be delighted, and we've got,
That would be awesome. That would be
yeah,
amazing.
well, we'll be at your disposal, so just let us know. That would be great.
Thank you very much.
Does anyone else have a quick question? If not, thank you very much for your time and great presentation. Thank you.